Are you already on Wikisana?
Welcome, dear viewers, to our natural medicine format. Today we're going to talk about whether trauma, a trauma diagnosis, has actually become a fad. What really is trauma, and how is it defined, and how is it treated? I have the pleasure of looking at this today with the head doctor at the Sonnenberg BioMed Center in Schwelbronn. This is Alexandra Kotthaus. She is a general practitioner, a specialist in general medicine, and a specialist in psychotherapy and psychiatry. And she will certainly give us comprehensive answers. Stay tuned. Hello, dear Alexandra.
Hello, Silvia.
I always look forward to the programs with you. We talk so much in between that the director has already stopped us. It's so exciting, and I think it's really great how comprehensively and on all levels you look at these things. We've already spoken in advance: fashion diagnosis, trauma. I've also experienced the other. Let's start with how you see it.
Yes, I experience so many different things, just like you, actually. You also have a psychiatric background, and if you have this psychiatric background, then trauma actually has a very clear definition. It's roughly divided into man-made trauma and non-man-made trauma. So something like catastrophes or traumatization inflicted on you by other people, although rather relative in psychiatry. It refers to things that are assumed to traumatize most people. Mistreatment, abuse, torture, more serious things. And that's just the way it is. I'm also a psychiatrist and have this background and this certain characterization. And you're taught a little bit not to extend this concept of trauma to all sorts of things. And at the moment, if you like, the fashion diagnosis is trauma, so we're all traumatized. I see tendencies at the moment where I have the feeling that, okay, we're going from these really blatant, hard definitions to the other end, and the whole world is traumatized. So I can't really comfort myself with that either. I think the truth may lie somewhere in the middle. So there are certainly people who have the image of traumatization or post-traumatic stress disorder. PTSD is also used here. I always hear it in German-speaking countries too. I hear the word PTSD more and more often. That's the English variant, post-traumatic stress disorder. These symptoms show, but not a trauma according to the diagnostic criteria. And yet I would still say that they are already traumatized. But then there are also mixed forms, perhaps. There are also people who have no memory of having been traumatized, which is also a protective mechanism. But what we actually all have, we all have more or less large and small injuries within us. We all have a certain amount of baggage in our backpack, and sometimes I'm not really ready to say inwardly, yes, these are all traumatizations.
Yes, I completely agree on that point, because I think you have to take a close look. I have also often experienced the flip side, and that has also changed a bit in the last 30 years. But because the issue of trauma or trauma treatment in many clinics, actually, for example, there was no trauma therapy ward, the awareness wasn't there. And then I also did Peter Lewin's training, but you're perhaps a bit more attentive there. And then I simply always realized that often the criteria for traumatization were really fulfilled for me. And on top of that, there was a psychiatric symptom. And because you didn't have this ward or whatever, you simply worked on the symptom on top of that. Or people who really say that there can also be very diffuse symptoms that are perhaps not so nameable. And if you really take a closer look, you can see that there is also traumatization in the clinical sense behind it. And the fact that people are perhaps often fobbed off too early, too quickly, that's also the other side, isn't it? I think so. And it's a matter close to my heart, for example, that these people are taken seriously, because they often have the perception of themselves that something is wrong with me, that something is not right. And if you can then explain what is happening in the system when you are traumatized, then that is often a great relief.
Yes, that also brings together many points for me. Maybe I'll start differently. Sometimes it's a relief to say, oh, well, that could be behind it. I have a diagnosis. On the other hand, that doesn't necessarily have to be the case if you treat it with respect. So that there is something and recognizes that and perhaps doesn't brush it off. Or say that psychosomatic is a term that even if you don't know what it is psychosomatic and is also an undefined, even pejorative label. Where certainly the other person is certainly not properly recognized. I actually find that I have very, very, very few patients who have what I call psychosomatic conditions. The majority of patients are more physically ill than you might think, even if they appear to have mental symptoms. And many people with real, let's say, post-traumatic stress disorder have several problems, including physical problems. And they also receive psychotherapy, although I would prefer to differentiate the term directly, because pure counseling therapy is generally not very effective. But let's say if you tackle the mental backpack, it makes their work easier if they have a functioning body-brain to fall back on. And I have also seen that people who have had their bodies treated properly no longer need psychotherapy, so to speak, because they can then fall back on the tools that they may have already learned. And on the other hand, you don't have to say, oh, that could be a trauma that you've got there. But there are now, I think, really a lot of therapeutic options.
Absolutely, yes.
Absolutely, absolutely. There are various ways to work on things and also to resolve them sustainably. I was once told, what does trauma therapy look like? The 5 pillars of trauma therapy are stabilizing, 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 possibly carefully confronting, stabilizing, and most of the time you don't really make any progress. You keep someone somewhere in a kind of limbo, not really bad, but not really good either. And it has to be said that there are now ways to solve this sustainably without re-traumatizing someone, which some methods also involve. I don't have the Peter Levine training, but you do. And I hear about that again and again, of course. And I think that's an interesting method. But there are now also other interesting methods. But you also have to get away from this idea that I have to know the trigger or I have to know the trauma in order to heal it. So this logic is not correct either. This method is a method that I can generally use well with someone who has average mental health in order to tidy up their mental backpack. There are exercises, whether you do it in a trance or in a guided regression, where you say, okay, what could have been behind this? What was the situation that led to the exclusion? The right way is to turn the parts that need care, and you can transfer that into the here and now, so to speak. This is a method that can have a lasting effect for many people, but not for everyone. And that may not be so easy or possible for someone who is very traumatized.
Yes, what you're saying really speaks to me from the heart, because I've also experienced that people have actually always worked so disastrously or once again into the story. And the story, it's not really not so, shall we say, relevant, is it? And then it's too much again, too fast and too overwhelming. Yes, and we talked about it briefly in the previous conversation that the soul or the cells or these, that is timeless. And today we can simply work with what shows up in us, but always in a very titrated, very gentle way.
Exactly. So for certain things, the saying that time does heal all wounds is not true. Yes, there is no time for the soul. For it there is a terrifying experience. And if there are certain triggers from an external situation, then what we have learned in the past is reactivated. We are 99% apes and have learned by imitation. And what we learned early on is deeply ingrained. We can fall back on it even in stressful situations. This means that even someone who has not been traumatized and is currently in a massively stressful situation will generally behave in a more archaic way or revert to earlier stages of development, because the brain always functions less well under stress. And a firefighter, for example, who is supposed to function well in an operation, knows that at the moment of the operation, we can only fall back on a fraction of the knowledge we have learned in the exercises. That means they have to practice for a real deployment. And that's a bit is the same for us. We have emergency programs that take effect at the end. And that's actually a good thing because it ensures our survival. But of course, in adult life, be very disruptive at times.
In general, in interpersonal cohesion.
There are simply very blatant forms of this. It might be obvious to everyone, but we often encounter it in very small, everyday situations. Actually, when someone's defiance comes out like that, you could say it's probably a reactivated old feeling.
Absolutely, yes. And how do you see it when you say that almost everything is actually also a bonding story?
It's been a few years now that I was actively involved in psychiatry. And of course, one of the topics there, theories of attachment. And at some point, a few years ago, I came across the idea that they had been refuted. Now, I've seen someone again at a psychotherapy training course with a book on attachment theory, and think like that, or sometimes at such congresses, then you have a young girl doing a study on mothers shortly after giving birth. I can't even remember what the topic was. Then why don't you have a child first to understand the whole thing? But she must have had a first-class degree because she was already a psychology student at that age, and you have to wait a long time for a place at university. But the life experience was simply missing. And now I've got a bit mixed up with the life setting.
Yes, the attachment theory.
The attachment theory. If someone who is not trying to sound nasty, I'll say normally intelligent, but now has a highly intelligent or highly sensitive child, then it's misinterpreted. There is this, what I know from before, this example was a child of kindergarten age, which is now being handed in. And if it doesn't turn to its mother, the mother can just walk out. Then it's attachment disordered.
Okay.
That's about it. And I think, no, certain aspects have not been taken into account. There are children who don't need to turn around to know that their mom is there or is going out or is there for them. So it's just too one-dimensional or too materialistic. There are simply no layers.
But what I personally see now is that attachment or relationships can have a healing effect, can't they? Afterwards also for people who are in an unstable situation, regardless of whether they're traumatized or not, right?
Yes.
But that doesn't necessarily have to do with everything being an attachment story, does it?
Yes, so basically we are all social beings, right? Monkeys. We are very similar to apes. Apes are pack animals, and there are safety nets. Even if things may not have gone quite so smoothly in earlier life, we also have mental safety nets in our bodies. And a pediatric psychiatrist once said that you can have a 60 to 40 mismatch as parents.
Okay.
So that the child is considered as a healthy adult. So you only have to do 60% well, and you can also be 40% wrong or not do things well. So you don't have to be perfect to be a good child.
But that's a great deceleration.
It's so nice, isn't it?
It's such a great feeling, yes. In hindsight, you always think, if I had known what I know today, I would have done it.
That's why you have grandchildren.
Yes. Okay. Yes.
Exactly. And yes, where was I now?
I was distracting you. We were there when we are social beings.
That we are social beings, exactly. And that just means that there are people who can do therapy, who need a counterpart for therapy. You can make up for that, so reparenting in New German. There are people who have perhaps only experienced something later in life, or who simply do it voluntarily to tidy up their backpack. I can see the differences there. Someone like that might find it much easier to get through their sticking points with a few exercises and need less support. Or you can say during an exercise that I've learned a new technique called brain spotting. I'm quite fond of it at the moment. And then there are people who go through it like that because they may have already done a lot of work and know each other really well. And that's brilliant. But there are people who simply need the other person or the help yourself, the therapist, because otherwise it becomes difficult. I can't really experience and learn if I'm only on my own. I actually need a counterpart. But how much of a counterpart or how much help I need is different. This certainly has something to do with how the first 3 years of life went or the pregnancy.
But now I have another question, because the title is actually Fashion Diagnosis Trauma. Did you choose that because you think that people hide behind it too often, or are misdiagnosed, or it's too common, or too much is put into it, or whatever?
Yes, that perhaps the term is sometimes used too quickly, that I would like to see a little more attention with the term. The term wasn't used at all on the training courses I recently attended. And these were extremely good and sustainable methods for bringing about changes in life or in the case of illness. I also found that very special and good. But I can see from several directions that I think if you use it too carelessly and then perhaps leave someone alone with it or don't accompany them properly, then I don't think it's actually nice to use this term so casually or succinctly.
Das nicht richtig begleitet, dann denke ich, ist eigentlich nicht so schön, mit diesem Begriff so salopp oder lapidar umzugehen.
Because we simply all have a certain amount of baggage in our backpack. We are actually all subject to the same mechanisms, how we tick. And there's a part of me that doesn't like to say that this is all a trauma, or that I need to seek trauma therapy. But I actually mean something completely different to what we both might now understand by trauma therapy.
Yes, okay. I understand that from this point of view. But I also think that ultimately it's probably about taking people seriously. Because, as I said at the beginning, in my opinion, people really are traumatized according to, let's say, the clinical criteria, and perhaps have somewhat diffuse symptoms and are then not taken as seriously. That's where it can be helpful. But I also think it's an interesting approach that you don't always have to pigeonhole it, but simply take people seriously and pick them up from there. I think the other thing is that we often have, let's say, dysfunctional beliefs or repetitions in our lives that we all fight again and again when we are not allowed to look at things so freely.
Yes, but these are also the things that put obstacles in our way, but they are also the most natural mechanisms that have ensured our survival on the other side. Otherwise, we would have the same thing every day. These are the same mechanisms we learn something, our brain saves that, like driving a car. And at some point it comes automatically, and we need less concentration for it. And the capacity is freed up for something else. And of course, we don't just have this with driving, we can also have it with dysfunctional habits. But the principle behind it is the same. It's just that sometimes the negative habits are more prominent and go deeper and stick deeper than the good habits. We have to be much more active, cultivate and nurture them.
I always say that these old structures are really like motorways. And the other thing, you first have to make like a path through the jungle. Yes, I find that very exciting. And if someone comes to you now, and perhaps under the title of traumatization or whatever, let's say psychiatric illnesses. We already touched on this in the last program, that the somatic often has so much more influence than we think. Do you just take a look at different parameters first? How do you go about it?
I listen to the patient and actually get a lot of information. Some patients themselves already have a good idea of what the problem might be. There are more typical interference fields or more typical things that I then look at on a physical level, not least the neck. And I always have to think of Rudolf Steiner. Psychiatric illnesses are sometimes much less mental than somatic illnesses.
That's a very exciting approach.
He actually said that. To put it this way, high blood pressure is more psychosomatic than depression. The word depression is also not a word that can be precisely defined. We have such a wishy-washy approach in this area too, because it overlaps with fatigue. And where perhaps in our organic scene we would also say mitochondrial problems or various micronutrient deficiencies. And this is actually also the case with burnout. And then for quite a while, psychiatric colleagues were reluctant to equate burnout and depression. In terms of the diagnosis rate, you don't have much choice, but you can actually say that depression is a spectrum disorder, like many other illnesses. But when I know that there are studies that say that doing 20 minutes of endurance exercise 3 times a week has at least the same effect as an antidepressant, if I do it for 3 months and if I look at the 1-year outcome afterwards, the sports group does better than the antidepressant group. And there is also a nice study on eating. They simply say that they gave a control group the same kind of social attention, and the eating group got of depression without antidepressants. And the social attention was taken out of the equation. And that means there must be something on a physical level as well. So I'm not averse to that. I mean, soul and body, mind and soul. However we want to express these things, or the non-physical things, they do belong together. But I would describe it like this: with one person, the physical is more dominant. I just get my foot in the door once I get the body in order. And in the state that most bodies are in, I actually always start with that. And there are people where the emotional part is more dominant. But I'm not just talking about traumatized or psychiatric illnesses. There are simply people where the soul is dominant over the body, including when it comes to the development of illnesses. And sometimes it's the other way around. It's not the same for everyone, which has the more serious influence. And then there are people where I first do the body, as well as I can, and then look to see if it moves and think that pretty much everything has been thought of. Perhaps the mental side needs to be taken into account again. But sometimes there are patients where the mental side is already so dominant at the beginning, and with the foreground, it needs attention first. And sometimes I can also work on both at the same time. We call these inpatients. We are not a clinic in the strict sense, but a day clinic. And when patients come here for 2 or sometimes 3 weeks, 3 weeks is actually a very nice period of time because you can build up a very good relationship with the patient and make a lot of progress. And then I simply have the opportunity, not just myself, but also other body-mind therapists there, that we can really pull together somatically and emotionally and work on everything at the same time. Then they come to our Carol, who does acupressure, where we have patients who can finally relax a bit. And then the next therapy is more effective because the sympathetic nervous system doesn't always fight it. And that's actually what I enjoy, fun for me to approach it. But it's individual. For one person, one thing weighs more, for the other something else. And sometimes you also have to, I also have patients I learned at some point in psychiatry, you can't rush things. I know that there are male colleagues here and there who are very quick to push women onto the trauma track and look for God knows what situations in the initial consultation. As a psychiatrist who has also worked with trauma therapy in a clinic, I would be a little more cautious. I first look at how things are and what's going on. And if someone tells me about their trauma in the first hour, I sometimes say no. Stop. If you can't take care of yourself, then I'll do it for you now. You don't even know me. You can't even know whether you can trust me, whether you want to tell me this. I know now that there is something. That is enough information for me for now. If that's all right with you, we won't talk about it any further. It's not going anywhere.
Wonderful. We're already over it with time. Nevertheless, I would like to briefly summarize that you really have to take all aspects into account and that you really have to work very carefully, regardless of which therapy you then apply. And that it's perhaps not so important what you call it, just how you approach it. That's much more important. Thank you, Alexandra, for being here again. That was very, very exciting again. Dear viewers, thank you very much for being here. I hope you were able to take something from this program. Stay healthy and see you soon.